So for the next portion of today's agenda, we are going to have a panel of folks from the field who are going to talk about their innovative approaches and problem solving. So I want to say for the panelists, come up here and join me at the table. Okay, great. Yeah, well, there'll be plenty of opportunity for you to give them some applause. We're going to go ahead and introduce. We also have some folks online as well. We see Bill up there, and I think Katie will be joining us in a second. Question for you all: do you want me to sit at the table with you, or do you want me to stand here? I don't care either way, but I'll stand here for now. But I might sit down. Okay. So hi everybody again, Stephanie Murray, she, her pronouns, and I am really lucky to be here to facilitate this panel. As I mentioned, these are folks that work in school-based health centers, and the purpose of today's panel is to really talk about some innovative approaches and problem solving that they've implemented. And you know, this is a small sample. I am sure actually we could have any one of you up here to talk about the sort of unique ways that you've sort of solved problems or sort of approached school-based health. But we are hoping that you'll leave this session having heard some new things that might pique your interest or give you something to think about to try at your site. I also just want to put a plug in that as you hear from them, if you are also thinking about interesting things that you've done that you think it would be helpful for us to know about, that would be really helpful. Come up to me after this session, and then we can make sure to highlight the great work that you do in future coordinators meetings. So we're also hoping that today's session is going to be informal and interactive. So, you know, use the, raise your hand, use the question, and if you're online, raise your hand anytime throughout this presentation, and we're happy to stop and ask questions to folks up here. So, I'm gonna go ahead and do some introductions, and then folks on the panel, if there's anything else you also want to say about yourselves as you go ahead and start talking, please do so. Okay, so up here in the middle, we have Elise Travertini-Winbigler. Elise works for La Clinica. La Clinica is a federally qualified health center that serves in Southern Oregon. Services include mobile and school-based services in 19 schools across 4 school districts. They have 10 certified sites and 9 uncertified sites. We have Katie Strawn online. Katie works at Multnomah County, and Multnomah County Student Health Centers is an SBHC program run by the local public health authority. It's been operating for more than 35 years in the Portland area, covering 5 school districts with 9 health centers. We have Bill Roller, also online. Bill works at Orchid Health, and Orchid operates 5 rural health clinics in Clackamas and Lane counties. Orchid Health was founded with the belief that our state's rural communities deserve to have accessible, high-quality health care. We have Alicia Holzapfel from Virginia Garcia. Virginia Garcia is a federally qualified health center with 18 locations, including 5 school-based health centers in Washington and Yamhill County. Virginia Garcia has been providing patient-centered care for more than 40 years. And lastly, but not least, we have Kristen Nicolescu from One Community Health. One Community Health is a federally qualified health center with 1 SBHC in Hood River. They're participating in the mobile pilot serving Wasco County in both Dufur and in the Dalles, and they're planning for brick and mortar SBHCs at those sites. So to start out, we're gonna start out with La Clinica, with Elise, kind of in the order that I introduced folks. If you wouldn't mind telling us about your innovative approach.
Yeah, thank you, Stephanie. Welcome everyone. I'm Elise Travertini-Winbigler. I'm here to talk to you today just a little bit about how we partner with school districts and how we have been able to open 19 sites, school-based health center sites, and financially really learn how to financially partner. I realize I'm a lot louder than financially partner with your school districts and what that engagement looks like. So I put together this slide, and I'll just kind of go through some of the bullet points. So what we've been able to do is we've met with some of our school districts. So we have, I want to say, at least 6 or 7 different school districts down in Jackson County. And all of those school districts do some sort of engagement process, especially when the Student Success Act funding came out. They needed to engage their community to say, what kind of services do we need to better support your kids in school? When that funding came out, as an organization, we put together kind of a white sheet to say, these are kind of the services that we provide, and how do they marry up to some of the Student Success Act funding pieces that you need to meet. And so really what we thought about is, what does your community want? What do you need to provide as a school district? And where do we marry with you in those services? And so when we came with the fact sheet, it's almost a model to say, come partner with us for 2 years. We as a health organization and an FQHC have the ability to bill something that Department of Education really doesn't have, right? They have the same needs that we want to fill. They need to have healthy youth. Mental health is the biggest driver, really, in terms of our partnership. So when we come in, we ask the school district, what do you need? What are you seeing are your biggest needs? And by far, I will say behavioral health, and I'm sure this is not a surprise to anyone in this room, is one of the biggest needs. And then we say, what do you have space for, right? Because school districts, space is at a premium. I'm gonna say space has sometimes become the biggest barrier for school districts to get our services in. And we as an organization created almost 2 different models. We have the Certified School-Based Health Center site, which everybody in this room should be keenly aware of. And then we have what I call the lighter meal deal. It's like the Happy Meal, and then the one that's for like seniors that just want to eat a little bit less. But it's really about what is the need of the school, what is the space, and then let's talk about how we can fund together. So in this financial partnership, when we asked what kind of services, we put together a pro forma, and that's just really a budget to say, this is what you're asking for, and this is my sample example of this is what you asked for. So if you ask for a full school-based health center, one that's going to be certified, and you're saying it's important for you to have maybe a therapist on site, you want a skills trainer or kind of a behavioral health provider who is not a master's level, but that could do groups and do check-ins and do screenings and all of the things. This is what the cost would be. What we know when we open a school-based health center is it takes about 2 years for a health center to really start to become truly functional. It's for the community to understand that it's there. Even now, some of the schools that we have been in 20 years, we'll do a school survey and they still don't know our services are there, which is just dumbfounding to me. But it takes time for them to know that we're there. It takes time for staff to know how to use us and to really kind of up ramp. And so our billables are usually a little bit less during those 2 years. And so what we do is we create this sample budget and we say, this is what we think we're gonna bill in the first 2 years. So if you see the highlighted number, that's saying this is what we're gonna ask from you, school district, to partner with us for the first 2 years. After that, and it feels like a sticker shock sometimes for school districts, because it feels like a lot, right? It's not cheap to open up a school-based health center, and I know you all understand that, because it really isn't. There's a lot that goes into it. But the great thing is after 2 years, they can take that funding and they can put it someplace else. We then continue our billing. They have their services so that if for whatever reason funding changes, because that's what happens, the new bright shiny penny becomes something else, that school district then has these health services that create equity and breaking down barriers to access to all their kids and families. And this is something the school district also has to speak to in their reports to Department of Education. So this is part of the model that we have done time and time again with the 4 school districts that we work with. their needs may change. And so I will give a really quick life example. Recently, as you saw the data earlier, substance use is a big concern for a lot of school districts. Schools are struggling with getting kids into treatment, and so they said, how can you help us support? Our role is not to be the substance treatment facility. That is not our role. But something else that we can do as school-based health centers is help link these school districts into other community resources that are out there. We tend to have better knowledge and relationships than maybe some of the Department of Education. And so we also then become this conduit of bringing in these resources. So if you don't have those resources and that's not your specialty, you may build the relationship with somebody in the community and be that liaison and help that process. And so this year, we're kind of doing that with our substance use. We have a person who is helping with screening and brief intervention, and that's where our lane stops. And then we've been building relationship with youth providing substance use disorder treatment facilities that are community-based so that it's easy for kids and families to get to. And we're helping bridge that gap between the school district's need and what services are actually out there. And I think that's about it.
Thanks, Elise. I have a quick follow-up question for you. So I think that this is really, it's nice and very practical. It's really nice to have some of the budget sheets, et cetera. It seems like maybe you would have to have some buy-in from your agency at large in order to be able to move a proposal like this, to like initiate it. Can you talk a little bit about what maybe the work that you had to do in order to get this launched?
Internally?
Yeah, internally.
Yeah. So internally, and I'm sure this is for many organizations, they want to see how can you financially sustain this, right? That was a big piece within in our internal process. Our organization is really focused on supporting youth, and it also, funny enough, aligns where the CCOs are going. Special populations, youth are one of their top populations that they want to focus on. And so we needed to show how financially we could make this billable. Our organization is able to bill for both the medical services and the behavioral health services. The behavioral health, we have behavioral health providers at our schools 5 days a week because that is the biggest need of the school. And most of our billable revenue actually comes from our behavioral health side and not so much our medical side. And so what we had to do is really show how financially we could bring those billables up with behavioral health and with our medical to make it at least revenue neutral. Most organizations, if you're at least revenue neutral, they usually move forward. And that consistently, we've been able to do this. So I've been in the organization for 18 years. I started off as a therapist, interestingly enough. And we had 4 sites when we first were there. And Ceci, who is with Rogue, she was with us at that time. And now we're 19. And this is not only important for internally in your organization, but also externally. Do what you say. There is a lot around trust and that you are reliable and that they can trust what you're saying. If you do that with school districts, they're going to be much more willing and wanting to partner with you. That consistency with those school districts is so important. And it's not just important for the school district, but for our families. And so it's the same thing internally. I'm just going to knock. We've been fortunate enough to, that department sits in the black in terms of like our revenue tends to exceed what our expenses are. And so, yeah, I don't think that's answered it, but I don't know if I have a better.
I think you did, and I think if it didn't, then folks can ask some follow-up questions. Sure. I think someone's running over with a microphone.
It's not about that. It's about something else you said. You mentioned having partnership or at least networking with outside set providers. Is that more of, hey, we're going to be a referral source for you, or is it more like specifically we're looking for this amount of particular slots, or is it kind of, do you have a few different type of options?
Right in the middle. So I'll give an example. We don't have a lot of adolescent youth substance providers actually in Jackson County. There's very few. And so part of it is, hey, will you be the referral source? But part of it is, do you want to come in with us to the school to do a presentation to the parents, because this is important for the school and getting the understanding about what's happening with substance use with youth to the parents. It's having those weekly meetings. It's saying, I have this kid and I really want to do a warm handoff. And that feels a little bit different than here's a referral and then go forth and do good things. And so this year has felt really different than many other years. Many years of doing this work, it's always felt very siloed. Nobody wants to partner. This is and I've got to get my people in. But the need has exceeded what, if you grabbed everybody together to serve, I don't think we could still meet the need. And so now they're partnering in a different way. So I would say it's a hybrid of both.
Thank you.
I'm going to move on to the next person on our panel. So Katie Strawn from Multnomah County. If you wouldn't mind talking a little bit about what your innovative problem solving and approach was.
One second. Let me see. Can you guys hear me? Yep.
Yes.
Yeses. Okay, excellent. Thank you. Thank you. Okay, so apologies for that. So as mentioned, I'm from Multnomah County, and the one thing I wanted to talk about today is our approach to dealing with the increasing issue of overdoses in our adolescent population, and looking at a specific harm reduction strategy that we decided to take on. And the way we did this was starting with a plan to do some PDSA cycles. So just to back up a little bit for anyone who's not familiar with a PDSA cycle, PDSA stands for Plan, Do, Study, Act. It is a cyclical, as the name would suggest, steps for change that includes your plan of exactly how you're going to implement the specific intervention that you're planning to do, and how exactly you're going to carry that out, and what your plan is for data collection, then actually implementing your intervention under the do step, and then studying it, looking at how your intervention, what that impact was, and then what learning points you can take away from it, and then acting on what changes need to be made in the next cycle. So applying this format, we looked at our specific question, and it's how can we in a school-based health center have an impact on the overdoses that are happening in our community. Just to back up and talk just a tiny bit about why we chose this as something to tackle. And around 2-ish years ago, we did have 2 unexpected, unintentional overdose deaths at one of our sites, and that was really a hard thing for all of us, and felt like we heard from the students, and we started hearing from places within Multnomah County that this is really becoming an issue that's now really impacting our population. And so went to the data also to look at this, and just to throw on a statistic for this group, the Suitors database, which is a CDC database that looks specifically at unintentional overdoses, has found that since about 2019 to 2021, among people from 10 to 19 years old, the median monthly unintentional overdose death has increased 182%. So that's a pretty staggering statistic. There's lots of statistics to show this. This is one specific statistic looking at the median monthly unintentional overdose death rate, but there's many others, and all of them are showing this an unfortunate increasing trend in overdoses in our adolescent population. About 90% of those overdose deaths involved opioids, and about 83% of those specifically involved illicitly manufactured fentanyl. I don't think that I'm talking to I don't think this is a shocking statistic to anyone. Unfortunately, we are all seeing this and starting to hear about this in our communities. And unfortunately, with the children that passed, only 35% of those children had had any sort of interventions in the past, were identified by the system as someone who was at risk. So one of the things we looked at, and when we started our planning phase, was what can we do within our locus of control at our health center, knowing that while we have great impact, we have to also look at what is possible within our system. So we started looking at things that we know we're really good at already. One of the things we know we're really good at is screening. We screen quite a bit. We screen, we're primary care, we do this well. So that includes craft screenings, SBIRT. We screen for PHQ2s, PHQ9s with all of our well checks, sports physicals, anytime there is any sort of concern for risk, and then ongoing screenings for anyone that's identified as high risk for specific substance uses, mental health disorders, et cetera. In spite of that, in spite of really, really good, robust numbers on getting these health assessments done, screening and using our primary care preventative screening tools in the year prior to our intervention, so from the 21 to 22 year, in spite of doing an incredible job of screening, we found that, and across our 9 sites, we had prescribed 1 dose of Narcan. And so to us, that really told us that something is not quite, something's not lining up with the pieces of the puzzle. And why are we not reaching these kids? Why are we not asking the right questions? So we decided to start looking at what else is within our locus of control. We know that we're really good at education. Kids come to us and we do education all the time, anticipatory guidance, that's part of all of our visits. And we know that at our clinics we can dispense. So when we started designing an intervention, we started looking at what are those strengths, screening, education, and the ability to dispense that could give us a unique opportunity to potentially set a harm reduction practice in place.
Stop bringing me in. Thank you.
Okay, so one of the things that we decided was, since we felt like we did a really good job of screening, and one of the things that we wanted to do was we wanted to change it a little bit. We know that CRAFT does an excellent job of identifying clients with the potential for substance use disorder, but there aren't any specific questions that relate to Narcan, and there aren't really a lot of specific questions that relate to what peer behaviors are. So taking some of the principles of screening that we know from reproductive health, including clients like and appreciate direct questions, and that asking about peer risk behaviors can also often be more impactful than asking for direct disclosure of personal high-risk behaviors. So we developed a 2-question screening tool. And I'll read the questions out loud, and all of these slides will be available afterwards if anyone wants to have any of this for reference. But our 2 basic questions were, do you think you may be around anyone who uses drugs or medications without a prescription? And it's a simple yes, no. And then, are you interested in receiving a prescription for Narcan today? So really direct questions, right to the point. So we decided that the screening criteria would be for clients who are not only at high-risk behaviors, which would include positives on CRAFT screenings, any positive answer on a CRAFT screening, but also scrubbing our charts for specific high-risk behaviors, such as already taking opioids, illicit use of opioids, illicit use of any medications, discharge from the emergency room, following any sort of intoxication or overdose, and then, like I mentioned, a positive CRAFT screening. We decided as part of our planning phase to also study and look at what is the best way to screen. I want to understand and respect and acknowledge that Every time we ask providers or any of our staff to do more, it's met with resistance because they do so much already. To cram anything into a 15 to 20-minute visit and then add anything additional on top of that is difficult. So we really wanted to understand what's the best way to capture these that doesn't put undue work burden on our staff. So we divided our 9 clinics into 2 groups. The first group would administer those 2-question screeners as a universal screening to all youth 15 and older during their sports physicals or their well child checks, so at least once a year. And that would be universal screening. The second group of clinics only asks those screening questions if the client had a moderate or high risk CRAFT score. So we really wanted to just see, can we really use it just as a reflex to the CRAFT, or should this be something that we should consider as universal screening? Part of that planning phase, and the planning phase is almost always the longest, so when you're designing an intervention, that planning phase really does need to take up quite a bit of time so that you're really thinking about all the different elements and really thinking about what the impact could potentially be. So part of that was on our screening tool, we actually put in not only a QR code to a link that shows what Narcan is and how to administer it, but also has a short FAQ on what is Narcan, what does it do, how do you identify overdose, so just some written materials that are right there on the screening question. The beauty of that, and the reason why we chose to do that, is because whether a child walks away with a Narcan prescription in hand, everyone is during that visit, during that well child check, during that sports physical, is educated on what Narcan is. They at least know what it is. They can at least go back and know that this intervention is there for them if at some point in the future they do need it, even if they didn't walk away with it during that visit. And then just another one thing that we did as part of our planning phase was we went ahead and built the Narcan screening right into our flow sheets tool within our EMR so that it could be easily documented, and that later on we could continue to, right now we're able to capture and study number of prescriptions written, and then future state will be actually being able to capture the number of students that are receiving education on Narcan. With that, our implementation was relatively simple. First and foremost, we notified our school district partners. We let schools know that this would be part of our offering, and invited any comments or questions. Thankfully, we actually had good support from the district school systems. We had a couple questions that we had to raise, and I'll talk a little bit about learnings, specifically around carrying medications in school, et cetera, using medications on and we'll talk about how we navigated that. Part of our implementation or due phase of the PDSA was making sure that we stocked all of our distribution cabinets with Narcan so that we would be able to do this intervention same day, rather than prescribing the medication and having the client either go pick it up or come back to pick it up. We were able to go ahead and do this same day, again, sort of following those principles of reproductive health care and understanding that you're going to see the highest adherence if you're able to do same day intervention. And then we, of course, did a full education with our staff, rolled out various tools, not only the screening tool itself, which is just a laminated sheet that goes in the exam rooms, but also little wallet cards that the student can take home that has the 1, 2, 3 steps for Narcan administration, putting that QR code on things so that students can look at that, and just building just a really quick but very streamlined education process so that we could give that intervention same day. All right, so just to jump into our study portion of our PDSA cycle. So thus far, we've done 2 cycles. The first cycle we implemented in February of this past year. And after 2 months of the intervention, we saw around a 300% increase in Narcan prescriptions. Not bad, but went back and did some learnings and realized that, you know what, implementing anything during IME exclusion was a terrible idea because everyone has just about this much capacity. So we went ahead and we actually did some targeted education with staff again, and did an additional education session with them. And when we last checked, our current Narcan prescription rate since introduction of this screening tool has gone up to, we've seen a 1,400% increase in our Narcan prescriptions. Now, before you get too excited, that's a really, really high number, but you do have to read the details. Since we only had prescribed 1 Narcan prescription, it actually doesn't equate to a huge amount of Narcan, but it is still a 1,400% increase, and we are still excited to see that we have had some success, and we continue to push towards that. We did see a slightly higher rate of Narcan prescriptions in the group of clinics that did universal screening versus risk-based screening. I will tell you that this data is still within the hands of our statisticians, so we have not yet been able to control for volume yet, but we will be hopefully rolling out some of those stats once we've controlled for actual volume and number of clients coming through. But raw data suggests that potentially universal screening is possibly a better way, or does have a higher impact in terms of prescriptions themselves. Really quickly, because I don't want to take up too much more time, but just to highlight some of the challenges that we had, certainly staff participation, as I mentioned, rolling anything out in ME exclusion. I hope you all, if you take nothing else away, realize that don't ever try to put an intervention in place during that time, because staff participation was a little limited right in the very beginning, but did improve significantly with just some targeted education. One of the challenges is that while the questions were built into our EMR, they haven't been seamlessly built into our one flow sheet that has our other screening tools on it. Unfortunately, that's proprietary. So it does require a couple more clicks in the EMR, and we have had some challenges getting people to actually use that flow sheet. Competing priorities is always going to be a challenge. Everybody's got lots of things going on, and that is certainly no different in our health centers. And change fatigue, just calling out that since COVID, there's been a lot of changes, a lot of doing lots of things for COVID and then unraveling a lot of those things after COVID, and everyone is just tired of change. So just really acknowledging that, and only so much you can do with that, but highlighting it as a particular challenge. And some of the limitations that we've had, we chose to purchase the Narcan through the 340B program. With that, it does require a provider visit, so we don't have a basket set up front with Narcan and just handing it out to students. We do require a provider visit with that. We have had some limitations with marketing, primarily because we did want to do a little bit of a soft rollout at first, make sure that we started to socialize this in our communities before we start papering the hallways of every school saying that we have Narcan available. We really want to make sure that we have our process tight and that we have our messaging clear, and that we start to socialize our communities before moving in a direction of some stronger marketing. School buy-in was not a major limitation, but we do continue to struggle with, and certainly everyone here on this call, understanding that right now it is district specific, but that we do not have carve-outs. ODE does not have specific carve-outs for Narcan when it comes to carrying medications in school and administering a medication that's prescribed to you to another student. And that is something that continues to be a challenge with using Narcan to its highest fidelity and using it the way that it needs to be used. And so that does continue to be a challenge. And certainly ongoing conversations and support will help to move that conversation along. And reaching an at-risk population, unfortunately, the highest users of narcotics and opioids are not always necessarily enrolled in school and coming to our health center. So I think that we still have some way to go to reaching our highest at-risk population. So all of that has now led us into our second PDSA cycle as we've started to get some of this data rolled in and looking at future state, which will be next PDSA cycles. We haven't fully decided what the next one is going to look like, but some of the options that we're looking at is a more sustainable low or no barrier dispensing practice, whether that would be through 340B MCAP or specifically outside funding to purchase the Narcan itself. We will be, with the support of Care Oregon, we have been able to hire someone, a community health worker specifically, that is going to help us with school-wide promotions and health class presentations that will focus on overdose prevention. We are looking at some campaigns that will be supported hopefully by some of the shacks or YACs that have been in our schools and have the ones that have specifically asked for support with overdose prevention in their populations. We're looking at rolling out various campaigns and asking them to pick some of there's lots and lots of campaigns out there around never use alone, or one pill can kill, et cetera, and having them choose which campaigns they feel would best speak to their student population. we are looking at and strongly considering medication-assisted treatment with Suboxone or Subutex as a future state for our student health centers. That is a very, very preliminary conversation, but we are working with another student health center and with OHSU. They have built a clinical practice guideline that looks specifically at what MAT treatment would look like in a school-based health center, and then certainly always looking at building partnerships with community organizations. So with that, I will pause and see if anyone has any questions.
Thanks so much, Katie. That's really a lot of information. I do see we have a question. I just wanted to say for everybody here in the room that, and I guess also online, that unfortunately I do apologize for Katie's slides not getting added to this presentation, but we'll make sure that they get sent out afterwards. And that Multnomah County has said that they would share their screening tool with everybody. And so obviously, as they're waiting to get all of their data in, we can make sure to check in with them to get some more updates about how that program is going. Question?
Yeah, thank you for all that. I think in some of our locations, we're looking forward to modeling a lot of what you're doing. I was curious about if there's anything set up, and I'm sorry if I missed this, with the study that you're doing that follows up with the students that you have given Narcan to. Have you used it? Did you give it to anybody else? Are there secondary requests so we can find out what's happening with the Narcan that's being dispensed? And I think that also would provide more data, like we have literally stopped this many overdoses because of this, or anything like that.
That's an excellent question. We don't have a formal follow-up process, but all of these kids, we are encouraging them to come back for regular follow-ups with us, and do have, they are going on our lists of kids that we're dispensing, and as we check in with them, we are sort of gathering and asking how that's going. But truthfully, what most of the kids that we are finding are taking Narcan because they do have peers or actually family members who they are worried about overdose. So thus far, we have not heard of anyone using it yet, but we are seeing sort of the slow and steady, I guess, growth of word of mouth as it becomes more and more widely known that this is available, and seeing large groups of friends coming in and asking and requesting this. So yes, don't have a specific follow-up plan, but I think that's an excellent thing to consider in some of our future PDSA cycles.
Thanks. We have one more question.
We have a question in the chat.
Oh, yeah, go ahead.
Oh, we had another question.
We
Sorry.
do, but go ahead and ask the question in
Sorry.
the chat first.
The question is from Jessica. Is there a way to access the student-specific MAT toolkit? Or Matt, I don't know if it's, yeah.
That toolkit was put together through I believe it's the OHSU Adolescent Medicine Clinic. So I believe they are happy to share that, although I am not the owner, so I would contact them and ask them about that specific guideline.
Great.
So this question,
It's on. It was on.
okay, so this question really is more around maybe college-age students asking the question about not wanting to get the prescription for Narcan in the event that their friend needs it, because it then goes into their, it's on their record as a prescription, and they're concerned about the ramifications of that, such as if they want to be a pilot or a physician or get life insurance. Now they have a prescription for Narcan, and could that have an adverse effect on those long-term decisions that they have from a professional level? Do we know that answer? Because I don't know how to answer that, so I thought I'd ask it here.
I think it's a great thing to bring up, and I think it's a good conversation to have with students. From what I understand, and with the narrative around Narcan, is that hopefully people are realizing more and more that this is really a harm reduction practice, and it is not a reflection of your personal practice. I think that as we continue to socialize this more and continue, as we all see that this is something that's needed, I hope that the stigma around Narcan will continue to decrease. There is an excellent a presentation actually that came out recently. It may have been AAP actually, around stigma and using Narcan. I'll see if I can find that and send that out with tools, because that is something that is continuing. But the more we prescribe and the more we socialize this, I hope that the more the conversation will turn less around stigma and more around this is something that you do to care for yourself and the people around you.
Kristen.
Push it.
You just started.
Okay. This is maybe a technical question, but I'm just curious how much it costs with your 340B and whether or not you're reimbursed for it. I know that'd be a question with my potentially my administration as I begin to purchase this to dispense it. How much does it cost, and are you reimbursed if you charge for it?
And I had a feeling someone was going to bring this up, and I should have had those numbers in front of me. I think that for the and nobody quote me on these exact numbers, but I think for 340B, the cost was around, it was between $15 and $25 per dose, I believe, and there's 2 doses per prescription, and then MCAP was about double that. We are seeing reimbursement for that because it is in conjunction with a provider visit.
One more question.
It's not. Hi, I'm Nancy Zink, and I'm not sure if it's specifically a question. But I'm the OHSU family medicine doctor that I've been working with Katie, and she's done an excellent job of presenting. I have made a medication-assisted treatment protocol for our clinic at Benson School-Based Health Center, and I'm happy to share that information later, and appreciate that Katie and everybody in Multnomah County is partnering together, and we're looking to create some youth-friendly outreach material. If anyone already has that, that would be great, because we're looking for that. So thank you.
Nancy, thank you so much for volunteering that. I did not want to volunteer your work, so I'm glad you were there to do that.
Great. Thanks so much, Katie and everyone. We are going to go ahead and move on to Orchid Health. Bill, do you mind telling us about your innovative approach?
Thank you, Stephanie. Can you guys hear me okay? Thumbs up?
Yes.
Okay. So just to give a little bit of a background for Orchid Health, we started as a rural health clinic back in 2014 in Oak Ridge, Oregon. And in 2016, our owners were deciding that they wanted to come up into the Clackamas area. And the Estacada School District approached Orchid to become the SBHC sponsor. And so what they did was they did a survey out in the community to see what type of services were needed. And it was determined that primary care services were needed, as well as school-based health center needs as well. So we actually went into the Estacada School District in 2016 as a school-based health center, rural health center designation. So that was our first school-based health center. One of the unique things that we do with our patients is we do provide first visits for our providers and patients, a 1-hour visit with the provider. And then every visit after that is a 30-minute appointment. Going in and surveying the community and working with the school district proved to be really financially sustainable for us in Estacada, because we were able to let them know that we would be able to bill out the patient's insurance. And also being part of the school-based health center, we really felt like it would be a hindrance to students if they weren't able to access the care, if they didn't know their insurance. So we don't charge any copays, or if they have a high deductible, we are not billing them for that. That immediately gets written off. And so we're really trying to be out there for the students in the school district to be able to serve the community. One of the things with the Rural Health Center, as well as an FQHC, is we have what's called a PPS rate with the state. It's a prospective payment methodology. And so for every Medicaid patient that we see, if a CCO, say Cure Oregon or Trillium or Pacific Source, if they pay us a specific amount on an encounter that is billed, we can then turn around and wrap that to the state for an additional amount of whatever our PPS rate is. And so for any Medicaid patient, that's how we have been able to sustain our operations. We then decided in 2021 to open up our next SBHC RHC in Lane County, and kind of went through the same things. We approached the school, had conversations with them, did a community workshop, and we've been there since 2021, opened up during the pandemic, and have had some pretty good success there as well. Like I said, we don't charge any copays or any other fees that are a barrier to students being seen. We provide telehealth services, integrated behavioral health, and we even have some patients that their insurances we just don't accept, and we write those off at no cost. Because of our strong billing foundation as an RHC, this is one of the ways that we've been able to go into the SBHC realm and be able to be successful as well. One of the issues right now, currently, we just opened our third school-based health center about a month or so ago. And it's just a school-based health center. It's not a community health center or a rural health center. And so we are seeing that there are a lot more confidential visits out there as well that are being written off and not being billed out. Some of the students currently don't even know what their health insurance is, even if it's not a confidential visit. So that is one of the barriers that we're having as well. And so we are going to be partnering with the school to do some education for students as well as family members, like who we are, how we're there to help them, how we're there to help the community, and stuff like that. We're going to do a little bit more marketing to that clinic. And, like Elise said earlier in her presentation, it does take a while to ramp up for SBHC clinics. And we have gone in and done several different types of assessments on potential clinics that we might want to go into the communities with, and some were feasible and some were not. And so you just have to do your due diligence on those as well. And that's what I have.
Bill, as a follow-up question, what kind of assessments do you do when you're looking at a community as to see whether or not, I'm sure all of the folks here or many have done similar types of assessments with communities that might approach them, but I'm just curious what Orchid does.
Yeah, we do kind of a community assessment of how many providers are in the area, what is the needs assessment, what services are around and close by, or is it 30 to 40 miles for the nearest provider? We look at the payer panels within that area of the community, Medicare, Medicaid, commercial, or if it's a cash pay community. And then we just kind of look to see if there are partners in that community that we can partner with, like a school or just any community-based thing like we have in Estacada currently right now.
Any other follow-up questions for Bill in the room? All right, thanks so much, Bill. We're going to move to our next panelist. We have Alicia from Virginia Garcia.
Hi, everyone. As you mentioned, my name is Alicia, and I use she, her pronouns and manage the School-Based Health Center program at Virginia Garcia. I'm going to talk a little bit about school integration between our school-based health center sites and our school sites. I think all of you probably have plenty of content in this area that you could share as well. And perhaps my agency wasn't the only one that had a bit of a struggle the last few years in maintaining good integration in our schools. I think we all saw the effects of the pandemic, not only in turnover on the school side, but also in our FQHC. and really ended up having a pretty severe breakdown in communication between the two that led to really poor utilization of our school-based health centers, and just sort of a lack of trust between the two because nobody knew who to talk to because everybody kept changing. And so a little bit about how we are slowly building back from that, I think, is trying to figure out, when we go into the school, who are going to be the key stakeholders. And I think those of us who work in schools know that that might be different in every school that we're in. And it's not the same title of person or the same type of person. It's just like trying to find somebody else who's an advocate for school health, who's willing to partner with you and support the work and the journey itself. And I think it's taken a long time to rebuild some of those connections and find out who those people are. And when I started with Virginia Garcia a year and a half ago, we had a site that had just really, really poor utilization during the school day, but seemed to have a lot better utilization before and after school. And we were really curious about it and asked students, why don't you come to an appointment during the school day? So there's plenty of availability. And they said, we can't leave. We can't leave school. I was like, well, you're not. The school-based health center is on your campus, so you're welcome to come. And oh no, they said they were going to call my parents if I left school. And we took that and we're like, okay, well, that's really interesting. Clearly we're missing some communication with our school partners here about the fact that we're all on campus together. And at the time, I only really had meetings at the district level with this particular school district. And so I asked the district partners, I said, we're hearing these reports from students. Do you have any ideas about, why they have that perception? And they're like, oh, that's because you're viewed as off campus. And in this case, the high school and the school-based health center are probably half a football field apart. So they are on campus. We're right next to the tennis courts and a field. And so we said, okay, but we're a part of your campus, so we're wondering why you consider us off campus. And they're like, oh, that's just the way that it is. That's what we've always told the staff there, so that's what they're communicating to the students. And I asked if we could potentially revisit that conversation, which led us to some key staff in the office, some office secretaries who were the people who'd received the communication that we were off campus despite being on campus. And so I had our staff and their staff meet and talk about, is there a different way that we can view one another that would support the movement of students? Because at the end of the day, everyone was just concerned about student safety. They needed to know where the students are. We totally understand that. They don't need to know the details of why they're in the health center, but we know that they need to know where the person is physically. And so we developed a system of between our front desk and their attendance secretary of open communication and trying to collaborate together to get both parties' needs met and also get a movement of students throughout the day without calls to parents and it being offsite. And they tested out the system for a couple of months. It seemed to work really well. This year, they've changed their system a little bit, but they've built that relationship, these two individuals, and they really it functions just with the two of them now. And I think that has been really helpful, and it was a great learning experience for me in that, those key stakeholders are at a broad range of levels. So in my experience, my key stakeholders in certain districts have been a custodian, and they've also been the director of social services for the school district. And I think everyone in between can be that stakeholder for you. And like Elise said, that despite the fact that you might be in a school or in a district for many years, there's still always this gap. Every year is a new year, and you've got to find those new people a lot of the time. But I think one of my biggest takeaways really was it doesn't have to be a particular type of person. I think initially we thought, it has to be a certain director at the district that we have to communicate with. And I think over time I've just learned that it's a lot more effective if the staff who are on site have on-site connections, that they build on-site relationships, and that perhaps if you have administrative staff, that maybe they're the ones that have relationships at a district level. And hopefully every so often you can all get together, and that makes things a lot easier. But I think that like depth of relationship and diversity of relationship have really helped with the utilization of the program as a whole. And I think we've seen that in the last year, at least at Virginia Garcia's program, a pretty significant increase in utilization, which I think we all attribute to the fact that the staff have done a really beautiful job of developing connections to the points that are relevant to their work. That's all.
Thanks, Alicia. I do have one follow-up. Oh, go ahead, Rebecca. You got a question online?
Am I on? Oh, okay. From Amber's school front office staff, et cetera, are really the gatekeepers for many things in our rural SBHCs. So I know this has come up a lot for other folks also about how students access the SBHCs and what information is shared and HIPAA and FERPA. And so I think this is a great example of how to get through that.
Yeah, and I think we've seen, I mean, a lot of us probably noticed, like, attendance obviously is a huge piece of this, like, and really, I found that just as long as the attendance office knows what time to what time, then you can get past a lot of the issues, and as far as getting them excused for the appointment without sharing information that is really beyond what we should be sharing in those cases.
Any other questions from the audience? I have a follow-up question. So I know that you've talked a little bit about how that relationship building happens, like where some of it is providing the right information maybe to the right people, or even, I'm guessing, touch points. Because I'm guessing, but my question to you is, are there regular meetings where front office staff would be there, or is this more like showing up to the front office to just have informal types of conversations and giving them the pieces of information they want? Does that make sense?
Yeah. I think it's different in different districts. So I do have one district where like the whole school-based health center team, all front desk staff, everyone is all together in those regular meetings with district and school officials. And then other ones where it's much more casual, I suppose, and it's informal and they're just wandering back and forth and know each other that way, I guess. So some of both.
Great. Got a question. Microphone is coming to you.
I have a lot of questions for you all.
Great.
I'm interested in hearing how, what you're saying about having attendants take care of the appointments and making sure. That's great. We're practicing that now, and it's a game changer. Mm-hmm. How have you been, I'm trying to think of a nice way to ask this.
You don't have to be nice.
And not nice to you, to our side of things. How do you go about getting the releases of information from the students for the school? Do you have each student sign a release of information for the school, or is it written into like a agreement with the school that's just implied?
Great question. So,
are there any attorneys?
I think the way that we've bypassed a little bit of that more formal, like the ROIs are still happening with like care coordinators or counselors or people who are like heavily involved. But the way we've bypassed it in certain districts with attendance is that it is just treated like a medical appointment, like students, any other medical appointment that they might have off campus. So all that attendance is getting is this student has an appointment, it is this time to this time. In the end, and they mark it as excused, but nothing else is getting shared.
Who approved that? I'm curious at your agency that was like, that works for us.
Oh, the powers that be on both sides have reviewed it all.
Who they are and get their thought process behind that. I have some people that I would like to share that thought process with.
Sure.
Thank you.
Yeah.
Can I follow up with that, actually? Are you asking, like, if the kids sign a consent to share their information that's shared with the attendance office? Is that what you're asking? Okay, so
Yes.
Okay, at our school-based health center, we just have a separate consent that the kid signs that says, I am allowing you to share our student ID number with the attendance office. It's like a separate part of the registration consent packet that we're using, and then all we share is the student ID number with a time in, time out with attendance, and then that gets shredded. That's all the attendance gets. Does that make sense? I'm
Yes, it
not
does.
trying to take
We're-
over your portion. but
that's, I
just-
mean, that's
Our
similar to
workaround
the-
is very similar to that. I was just really curious the specific like legal or privacy compliance advice that y'all get, because it doesn't seem to be consistent. But I mean, that's how it goes.
Yeah, and I think it has been different in different districts.
Yeah.
Which is always the case, unfortunately or
So-
fortunately.
So in our school district, they sign an ROI to the school. And even on our ROI, there's a statement that says, we may share information with the school to promote the health and well-being of the student. So it doesn't mean that we're sharing everything, but it's like, does this kid need to be up closer because we can't get the glasses? We're going to talk to the teacher about having them sit closer so that they can see the board. But our kids and families sign one specifically to the school. And just the same on the FERPA side, and I don't want to get too far deep into the weeds of this, we have a legitimate education concern form on the school side so that they can say, for especially your younger kids who are not accessing it on their own, little Johnny is up here and feeling ill, can we send them back? And so then we go through our consent pieces, but just for them to do that call, there's some of that. So you have to have things kind of in place on both sides.
All right, thank you.
Hi.
If you keep on talking. Hi, hello. My name is Topanga. I'm totally new to the school-based health center, and I'm at Neocani on the coast. And I have a question regarding how do you guys go about reminding students about appointments without doing the calls, and how do you coordinate with the staff at the school to help assist those students to get to appointments? Our students are very strict about phones and leaving class and attendance. We give an attendance sheet that has their names on it and the times of their appointments, but we're going back and forth on ideas on is it the student's responsibility to make it to their appointment, or is it the staff's responsibility to help them make it to their appointment, or is it our responsibility to call the staff member of the class they're in to make it to their appointment? And it's just been an ongoing head-butting situation that we have not figured out, and I'm really curious on your guys' input.
So in certain places we do reminders through a text reminder, but the phone thing comes up a lot, and we do have reminder cards or things that state very clearly what the appointment is. I feel very strongly at the end of the day, it's the student's responsibility to get to the appointment that they have created. And so obviously we want to take down any barriers that prevent them from doing that, but we're not going to get involved with calling staff in order, calling classrooms or anything like that. We are relying on the student to self-advocate, and then if they face a barrier in that process, we usually find out about that later and then try to go kind of backwards for the next time.
I second that wholeheartedly. I think staff from both agencies, both the student-based health center and the school, have better things to do than chase a kid around trying to get them to show up to their appointment. So I encourage you to not do that. But then I would also say that the main barrier that I found is just school staff education, and the easiest way that we've been able to kind of get around a barrier, kids can't show up to the appointment, they're not being allowed to leave, is just wholesale education with school staff to say, if the kid says they have an appointment at the school-based health center, please let them leave. Attendance is being taken care of on the back end. You don't need to worry about that student. We're taking care of it from an attendance perspective. And so every year we have a conversation with school staff about how the attendance process works, so they have buy-in, so they buy into the process.
I actually do have a follow-up question to that. Does the philosophy at all change depending on the age of the student, as we're talking about? Because I think, I know, Kristen, for instance, you work in a high school. As we're thinking about kids from elementary or middle schools, is there a little bit more support, and what would that look like? I don't know, Elise, if you want to talk a little bit about it.
So we have 7, 8, I don't know. We have a lot of elementary schools. It does look different for elementary school because the kids aren't consenting for their own care. They don't have this prefrontal cortex that is fully developed to do the thing. And so it looks like calling into the classroom to say, can we, and it could look, it depends the school. It could be looking at calling into the classroom. It could be having the kid go to the front office and then a staff member meeting them and bringing them back. It just really depends on the school environment. But littles, you can't expect to actually make it to their appointments on their own, especially, you know, when you're dealing with elementary school aged. Yeah, I agree with you, Ceci. Middle schoolers kind of fall into that as well.
All right, we'll move on to our last Oh, we have a question. Go ahead.
Sorry, I was just curious. You just sparked my interest with that comment. So with age of consent, how are you seeing kids under the age of 15 without a parent present?
Yeah, so we send out consents to parents. Good God, that's loud. So we do send out consents to parents every year. So every kid in the school, in our elementary schools, get the consents. And so the way it works is we either get the consent or we don't. If we have a kid who the school's concerned about, or a parent says, I'd like you to see my kid, and we don't have a consent, we do a one-time verbal and we'll document it and send the paperwork home. But most of our visits, it's kind of the beauty of school-based is that parents don't have to miss work to bring their kid to the thing, and the kid doesn't have to miss a ton of school to get to the appointment. Our nurses or our MA or provider, depending on how that visit goes, will give a call to the parent and send an after visit summary that goes back with them. If it's a provider visit and they need medications, they'll start talking to them about what's your best pharmacy and all of those pieces. So the parents are always involved, but not all visits do parents on campus for.
I have a question. I have so many questions. How do you get I'm a medical provider, so I'm obviously thinking of all the barriers to seeing a young kid without a parent. It's driving me wild just thinking about it. So how do you make sure you get a comprehensive health history when you don't have a parent? And how do you do all the front work on that kiddo so it's not this giant situation?
So, well visits, we try to have the parents there. So let me just put that there. And then we also send home the health visit summaries for families to fill out. If there's any questions, we can contact the parents on the phone. So they're not necessarily coming in. And I have my nurse manager here who can probably answer more to this.
You're thinking the medical history form.
Medical history, yes.
We send that ahead of time. But if the kid shows up and there's definitely questions, we'll call the parent on the phone and we'll get their history of whatever's going on. And then, of course, we document and we've got it in the chart. And then probably that kid's going to come back again and we've already got that history.
That's a really time-intensive appointment.
So a lot of if it's that sort of appointment, it's usually handled by the nurse. So we have nurses operating separately from the providers. And so a lot of that will be handled by the nurse as opposed to the provider. And if it was the provider, the MA would probably be obtaining some of that information from the parent if we needed it.
Awesome, thanks.
Just keep talking. Okay. From Carolyn at Siskiyou, we have the ability to send a link to the parent via smartphone or email, which they can fill out on the spot. Works great if we can get a hold of the parent by phone to see if they want to give consent or not. So you send it through the phone, text. Excellent. Okay.
And I'm guessing that is linked up with their EHR?
Carolyn, is that linked up with your EHR?
I know.
Thumbs up. Okay, anybody want to talk to Carolyn? You want to put your information in the chat.
All right, we'll move on to our final panelist. Sorry, Virginia Garcia, you had one more slide. But here we go, One Community Health. If you wouldn't mind, just Kristen talking about your innovative approach.
Hi, everybody. My name is Kristen. I'm a physician assistant. I work at One Community Health, which has one school-based health center in Hood River. As you guys know, Hood River is about 70 miles east of Portland. We have a fairly large service area as an FQHC at One Community Health. And I was brought onto this panel to discuss how I am working on expanding school-based health services into more rural areas of Eastern Oregon and central Northern Oregon along the gorge, specifically into Wasco County and towards Dufur. So and then specifically how I'm bringing in comprehensive adolescent healthcare services, specifically contraception into those areas where it's sometimes a controversial or maybe a contested issue. Thankfully for me, as the first place that we're starting to open up is in Dufur, which is about, oh yeah, I wanted to show you guys the mileage. Dufur's about 40 miles away from our current school-based health center, but it takes about 45 minutes to drive from place to place. So they had received some grant funding to look into opening a brick and mortar school-based health center, and they had approached One Community Health to become the medical sponsor of that school-based health center. And I was tasked with kind of looking into that to see if it was viable. The reason I'm on this panel is because I've been trying to figure out how to get school-based health services into more rural areas since I started at One Community Health. We know that the communities around us are like very, very high need and very underserved, but sometimes it's not super financially viable. And so the way that I've done it is we've been thankfully offered and applied for and been a part of several grants. First of all, we started with a behavioral telehealth grant, which we placed portals throughout our service area so kids could receive virtual behavioral telehealth services. So currently we have 6 portals throughout the area. We've got 2 in the Hood River area, but more specifically expanding services eastward. We have behavioral telehealth portals in the Dalles. We have one at the Dalles High School, one at the Dalles Middle School, one in Dufur, and then another out in Maupin, which is pretty far away. So 65 miles away, 90-minute drive away from Hood River Valley High School. These are places that don't have behavioral health care, as you guys are aware. They have school counselors, and it takes a long time to get into the Dalles, which is the nearest city where they could potentially receive behavioral health services. So I've started to expand that way by offering behavioral health services. As you guys know, that's the top request from all of these schools. And then subsequently, we have also been part of a grant process for delivering mobile healthcare services into Wasco County. So we were, I think, was it Virginia Garcia? Did you guys give us mobile? No, Mosaic did. And I'm not sure if Mosaic's here right now. Anybody from Mosaic here? You guys gifted us with your old mobile van that is still running up and down. You drove it? They've asked me to drive it, and there's no way I'm driving that thing. Yeah, you do. Good job. I'm 5'10", and I'm not doing that. So we are using their old RV, and we are taking it to the Dalles and more frequently to Dufur as we are awaiting brick and mortar school-based health center in that area. We did remodel it a touch, but I think it's still got the same engine. It's like still cranking from 1992. So. That's how I started expanding services into more rural areas. And I think the success about it has been that the more you're out there and the more you're providing services, the more people in rural areas get used to seeing you, get to seeing the name and the van and your face as you go to places. So it makes them more comfortable as you're kind of coming into places saying that you want to provide more school-based health services on a regular basis in a brick and mortar. So that's a really basic presentation about what I've been doing, but more specifically, they wanted me to chat about how I'm bringing contraceptive care into those areas. Thankfully, Dufur had approached us, and so I had a card to play, which was like they needed a medical sponsor. There aren't a lot of medical sponsors in the area. And so when chatting about how to provide comprehensive adolescent healthcare services, contraceptive care and dispensing contraceptives was sort of a non-negotiable for me. So if we're going to be the medical sponsor, there will be a dispensing pharmacy, and I will be providing comprehensive contraceptive care in those areas. Otherwise, the point is basically nil in those areas for me to provide care. I understand it's important to provide well child checks and sports physicals and make sure that you have mental health care resources, but we know that comprehensive medical care also includes contraceptive care. So that was sort of the package, right? If you want us to be the medical sponsor, this is the package I'm going to offer you, similar to a budget that you take to a school district. This is the package I'm offering you. There were some conversations with school boards, like, can we kind of pick and choose, like, a la carte, what sorts of services you offer? And the answer is no. I'm sorry, but no. So that's, well, I mean, they may be desperate, but I mean, that you get what you get when you can't complain. So I think that is an approach that worked, and the reason it worked was because I think, frankly, it was because I wasn't an administrator going into sorts of community meetings, et cetera. I was a clinician who was providing the services and explaining how they would be provided. And so maybe a word of advice for people who are trying to bring those services to more rural areas is potentially take somebody who's actually providing the services and those rural services to talk about what an appointment would look like, what a contraceptive and educational visit would look like in practice. Another big question is things like gender affirming care. So in rural areas, they have a lot of questions about abortion access, contraceptions, and gender affirming care. I would say that if you take a clinician into sorts of community meetings or in front of school boards, a clinician who's actually doing the work on a day-to-day basis, I think it can be really beneficial as people understand what that appointment looks like in practice. Rather than having a CEO go in or a CFO or maybe a more administrative person, I would recommend sending a clinician in. I think it's really helpful. And a clinician who's a champion for that kind of service and who works with adolescents and young people on a day-to-day basis. Any questions?
I have a question not about contraceptive care, but a little bit about your portals. Who is connected? Who helps the student connect to those services in the school? And what kind of work do you have to do with that person ongoing in order to make sure that, and that, like, what's the appointment setting look like? Like, I'm really thinking about, like, the logistics of that.
It changes every year. We had set up talking spaces in each counseling office, like whether it was like a broom closet or a dedicated room. As you guys know, there's not a lot of space in schools, so we set up private, confidential areas. They're usually in the counseling office, and there's one person at the school who grabs the kid from class, it's usually at middle schools, to bring them down to the counseling office and get them hooked up with the appointment. The platform is Zoom, I believe, and it integrates with our EHR. And yeah, it's Zoom now.
So the counselor does the appointment setting, like essentially the counselor identifies.
We send a weekly email that says these are the kids who have the appointments this week. This is the time it's at. They have a special appointment link that's confidential that integrates with our EHR, and they have a password for that appointment. That's all sent with each portal and with each appointment time. I'm not my front desk jack of all trades person is the manager of this program, so she could speak to it a little bit more, but it requires a lot of upfront work, as you guys can imagine. If everything's virtual, the first appointment needs to be with parents, especially if they're young kids. So you do an initial appointment virtually with parents present and the behavioral health consultant. And then everything else subsequently can be during school hours without a parent present.
How often are you taking the mobile vans? And do you feel like that's meeting the needs, or you could go every day, or?
I think currently we're going to do for about 1 to 2 times a month, depending on schedule. Dufur is a school of 330 kids, K through 12. So we are developing an unaccompanied minors policy currently and how to work that, because a lot of the kids we would see would be under 15. We don't have a lot of demanded due for currently, so I think that once a month would probably be appropriate with the mobile van. And then the Dallas High School, we're having a little bit harder time with buy-in at the district, right? So just like having a champion in the district is so, so important. Somebody who wants you there, who's like constantly checking in with you. If you don't have a champion within the district, it's, you can say you have resources for days and they may or may not take you up on them. So we're going there about once a month as well. I think if we were there more often, we'd have higher volume. I think consistency is key with mobile stuff. It's also limited by budget, frankly. So we're with a grant budget. The budget, do you remember what it is?
It's $120,000 over a biennium.
Yeah, okay, so $120,000 for 2 years to take a huge bus out with myself and an MA and a driver and gas. And so it's all limited based on what that budget will allow for. So we've budgeted it out, and I can go 40 times over 2 years to these 2 locations, hopefully concentrating more of that at the school that has a larger population would be in the Dells. I'm not allowed to go any more than that. Can't go over budget. Anything else?
Any questions from anyone in the room?
Actually, I do. Hearing that, so then are you doing billable visits? So you have your 60,000 from the grant, and then you're billing, so that should increase your, well, I guess your personnel would be expensive. Yeah. Okay, never mind.
I'm very expensive. Just teasing.
Van maintenance.
Mobile
health maintenance.
Van maintenance is really expensive. You're paying a driver, because nope, I won't be doing that. Paying a driver, you're paying an MA and myself potentially.
And gas.
Gas
I
is
was
ridiculous.
gonna say, gas to get all the way out there can be a lot too.
Insurance and then overhead. So we include all the overhead into that budget. All the supplies that I'm bringing on, all the meds that I'm dispensing. So it adds up pretty quick. Also remember that most of the visits are confidential. So a lot of those are written off. They aren't revenue driven. So if we do a sports physical day, sure, that's revenue. But certainly if you're doing confidential visits, and a lot of that is written off.
I'll just put a plug in that if anybody is interested in mobile and wants to learn a little bit more about how it's going, I will say it still feels pretty new for the folks in the grant, including One Community Health, but we're happy to meet or have you join any of our meetings to talk through what that is looking like. All right, any follow-up questions from folks online? I have a couple. So I don't know, Katie's off video, but I don't know if Katie, you are still there. Great. I was wondering if you wouldn't mind talking a little bit about the other PDSA work that you all are doing around youth engagement, because I think that might be interesting to folks in the room.
Sure. I can speak to what we're trying to do and what we're hoping to do, which is when we give our clinic tours, which we typically invite not only our YACs or SHACs, but also our health classes. When we give health class presentations, we invite students to come through for tours. And traditionally in the past with our tours that we've done, we've asked them to fill out a form that oftentimes the teacher is looking just for engagement and have questions, but have added a section on there to provide feedback for the clinic. And we are taking that feedback back to our monthly team meetings and asking them to look at potential QI projects in that PDSA format, and asking clinics to start to run those PDSA cycles or interventions. It's usually going to be relatively small, but hoping to try to improve our clinics and get feedback directly from our youth in that format.
All right, we have just under 10 minutes left, so I just thought we might end with each of you saying a little bit about if you, in thinking about the approach or sort of the problem that you solved and what you would want to tell the audience, if they either were facing that same issue themselves or wanting to implement your approach, what's one thing you'd want to share with the audience? And we can actually just go down the line. So we'll do Alicia, Elise, and then we'll go to the folks that are virtual.
Well, I think that the key factor in us even figuring out that there was a problem was that the students voiced it. And so I think that it's being in tune with what's going on with them and being willing to take their feedback about how things are going, because that's really what set the whole thing in motion, was the students were telling us, like, we can't get here, and we wouldn't have really been able to figure out why not without them. So engage them.
I think I would say make sure you're matching up the needs of the community with the needs of the school. Learn school speak. It is Department of Education speaks a little bit different than OHA. And so that they can understand what you're actually trying to achieve and that it marries well with their goals. I mean,
I think when trying to expand into areas that may be resistant or have a lot of questions or are hesitant, I think the answer is sending someone into those areas to advocate and communicate on a regular basis with community members, who is a huge school-based health services champion who's super passionate and does the work on a day-to-day basis. They can answer very specific questions and concerns that people have. I think that's the main thing that I learned going into a very rural community, was it was important to have somebody there who's very passionate about it.
We'll go next to Bill.
Yeah, I think for us, like everyone has said, learn your community, learn what the school needs are, but also I think education for the school and the community and the parents as well, because they don't know what they don't know, right? You want to be able to provide the services, but you also want to be able to be sustainable, at least at a break-even level, to be able to stay there to provide the services. And so I think a lot of education and partnership is what's needed between the schools and the clinics.
Katie?
I think making sure that prior to any intervention work or innovation that you do, checking with your staff and making sure you have buy-in first, making sure not only that you have buy-in from them, but ensuring that you've really connected them with the why of the work, why that work is important, why they may need to work a little bit harder, why you're asking them to do more, because without that staff buy-in, it's not going to work.
So I think we've heard you need to check in with the students, the staff, your community, the school, which is not, I think you all are well aware that the SBHC really functions well as kind of a linchpin of the community. I think you're all doing this great work. I'd like for everybody to give a round of applause to our panelists here. And we're going to go ahead. Kate is going to kick us off for our break.